Well, good afternoon, everyone. This is Sean Walker, and I am welcoming you to the second meeting of the Comprehensive Health Coverage Commission. We are very pleased to be with you today. The format for today's meeting will follow the same format for our last meeting, in that we are inviting the public to listen in to today's discussion. Our commission members will have the opportunity to unmute themselves and ask questions and offer feedback throughout the discussion. And following the conclusion of the meeting, we will work to get the meeting recording as well as the presentation posted to the commission's website. So you will be able to access the meeting materials and the meeting recording through the website. Today's agenda, in a moment, I will perform an official attendance or roll call for the commission members. Chair Nagel will provide her opening remarks, and then we will have a presentation by Grant Thomas, who's a Deputy Commissioner of the Department of Community Health, and he will share an overview of the Georgia Pathways to Coverage program, as well as an overview of the uninsured population in Georgia. And then we'll close out the meeting with new business and closing remarks by Chair Nagel. So with that being said, I will, thank you, Kyle, for progressing the slides. I will get into the official roll call of the commission members. So members, once you hear your name, if you can unmute yourselves and then confirm your presence. Kaylee Nagel.
Thanks, Sean, I'm here.
Lisa Carnott.
Thanks, I'm here also.
Thank you. Pam Clayton.
Good afternoon, I'm here.
Thank you. Christy Klein Davis.
Hey, Sean, I'm here.
Thank you. Delvecchio Finley.
Afternoon, I'm here.
Dr. Harry Hyman.
Good afternoon, I'm here.
Thank you. Dr. Sid Moore.
I'm here as well. Thank you.
Thank you. Dr. John Odom.
Present.
Thank you. And Rusty Ross. Rusty Ross. I know he was on earlier. He may join us again. Chair Nagel, that concludes our roll call for today. I'll turn it over to you.
Thanks, Sean. Real quickly, did you want to share with the public that's on the call about the email listserv that you're creating?
That's right. Thank you for reminding me about that. So if you are interested in joining our distribution list for notifications of, commission meetings and materials that are posted on the website, please send an email to the commission's email address at chc.commission@dch.ga.gov. It's displayed on the screen here. We will add you to that distribution list for meeting notices or future meeting notices. So please be sure to join if you're interested.
Thanks, Sean.
Thank you
so much. I know that's not easy for y'all to corral and keep track of, so I appreciate it. Couple updates for me and just some introductory remarks. Hope everyone has enjoying early fall weather a little bit and has had a smooth back to school. I want to take just 2 quick seconds, I guess a point of personal privilege, and just recognize and extend thoughts and prayers both to the families and loved ones of those victims that were impacted by the tragedy at Appalachian High School yesterday, as well as to a friend and former colleague of many of us, Earl Rogers, who passed away over the weekend as well. So just I hope you all will join me in keeping all of those families in your thoughts and prayers as we embark on our work today. Commission related updates. I've been working with the department pretty closely over the past few weeks to bring on board the consultant that the governor and legislature so graciously funded for us to support this work in the budget. I think it was $200,000 to help us at least get some initial work accomplished and a report, at least an interim report issued in December and beyond. I think by semi-annual reports thereafter. So given that dollar amount, it does require some state contracting and procurement guidelines to be followed, and we're following those. We'll most likely select from a vendor that is currently on statewide contract. And so Sean and her team and the procurement office at DCH is helping to lead that effort on our behalf. Once we get a contractor selected, we will bring them up to speed pretty quickly. I'll work with them pretty quickly over the remainder of September and October to try to get them up to speed and get ready to help support the work of our first report due in December. So stay tuned for more in that. I don't want to forget, it is later on the agenda for today, but potentially a save the date for a next meeting of October the 24th. My gut is that will be virtual as well, and tentative pending how far we get that consultant on board and the work that we need to get them ready to do to start writing at least something for our initial report. Beyond that, potentially another meeting end of November or December, potentially in person if we can find a suitable location and a date for everybody to do that and to travel, but really flexible on that. So I'm excited about the conversation today. I'm excited about the conversations that I've had with a number of you over the last few weeks about ways that we organize this work. December is not the end date, rather it's just the first check mark, and this is a 2-year effort. And so how we go through and categorize these topics and make some meaning out of the areas that we can really examine kind of from the lens of our charge that we talked about in detail last time, access, quality and patient safety, and service delivery and coordination at a high level, how we thoughtfully move through each of those buckets with the right presentations from the right people. I think last time, I still want to extend another thank you to the team at DCH and to General King for helping lay the groundwork on our understanding of both Medicaid and the Georgia Access and the Office of the Insurance Commissioner and Safety Fire. And today we'll follow up on that. Grant Thomas, Deputy Commissioner at the Department of Community Health, is going to take us a little bit deeper into our current 1115 waiver, Georgia Pathways, and talk to us about what it is, who it offers eligibility to, and a little bit about the uninsured population in Georgia. We had several questions from the commission as we kind of rounded out our last conversation about what does the whole makeup of Georgia look like? What really is the true uninsured number that we're really talking about? Specifically within Medicaid, those folks that are really under 100% FPL or even 138, what does that number really look like? And I think we've got the right person on deck to talk to us today, and Grant Thomas has pulled together some resources. So for the commission members, I think last time, to help me moderate questions and field those a little bit, I think you can shoot me a chat individually and also use the function to kind of raise your hand on the Zoom function, and I'll call on you when there's a natural break and can ping from one to another. So with that, let me introduce and turn it over to Grant Thomas, who is no stranger to the healthcare world, certainly has joined DCH within the last year or so, and previously the director of the Office of Health Strategy and Coordination within the Office of the Governor, and has worked in healthcare policy and a number of different organizations prior to that, both including at Children's Healthcare of Atlanta and at the University of Georgia. And I'm really happy that he agreed to spend some time with us this afternoon. So Grant, thank you for being with us. I'm going to turn it over to you.
Thank you, Chair Noggle and commission members. It's an honor to be here with you all today, and thank you for giving us this opportunity to present on Georgia Pathways, our 1115 waiver, as well as the uninsured rate in Georgia, and talk a little bit about Georgia's comprehensive approach to offering healthcare coverage and access to low-income Georgians and all Georgians. Definitely echo your remarks. Thoughts and prayers are with all those impacted by the events yesterday in Barrow County, and also condolences to Earl Rogers, friends and family of Earl Rogers, definitely in our thoughts and prayers. So I first wanted to just let everyone know, I think a lot of you were probably tuning in online and virtually on Monday, August 19th. But Governor Kemp, our commissioner at DCH, Russell Carlson, and Insurance and Safety Fire Commissioner John King had the opportunity to present on the Patients First Act at a Patients First Act roundtable And I encourage anyone, on this call, members of the commission or, members in the public tuning in to go and watch that. It was recorded and it can be found on the governor's YouTube channel or the governor's Facebook page. So some really good information shared during that roundtable discussion. Look forward to discussing more on those topics during the presentation today. Commission members, you should have also received 2 one-pagers that we shared intended for the commission related to marketplace data in Georgia, uninsured data, as well as coverage options, healthcare coverage options that the state has sponsored. And again, I will go into that in more detail during this presentation, but just wanted to call those things out before we got started. So we can go to the next slide, please. Next slide. These are just some introductory slides. Okay, so this is the agenda for today, just to give commission members an idea of what I'll hope to present on and discuss. First, we'll start with a program history of the Georgia Pathways program, how it originated through the Patients First Act, and also importantly, how it intersects and how it's related to other healthcare coverage programs in Georgia, specifically Georgia Access with the health insurance marketplace, the individual marketplace. We'll go through historical uninsured data statistics so that commission members, you all can see kind of the history over the last several years, specifically within Governor Kemp's administration of uninsured numbers and, how that has progressed over time, what they were when the state developed Georgia Pathways and Georgia Access back in 2019, and then what they are in the present day. So that's where the 2022 uninsured data comes in. And just a call out there that uninsured data, typically it's on a lag. It comes from the American Community Survey, and that uninsured data is not real time. So realize we're in 2024, but the most up-to-date uninsured data that is recognized, across the country is the 2022 census data. So that's what we'll be working from. Just a note, there will be 2023 uninsured data released later this fall through those surveys and the census, but it is on a delay, so you have to keep that in mind when looking at these numbers. Then we'll go through the marketplace overview to see kind of the marketplace population, what that enrollment looks like. Specifically important, given that so much of the enrollment in the individual marketplace, at least in Georgia, is under 150% of the federal poverty level. So 64% of the enrollment is actually in between 100 and 150% FPL. So that's very important when talking about how that relates to Georgia Pathways and our Medicaid program, because those dollar amounts are very close to each other. And then finally, we'll go through the Georgia Pathways program, provide a program overview, like Chair Noggle said, and talk about the different components of the program, services that are offered as part of that coverage, who it's intended to serve, who can qualify for eligibility and enrollment in that program. So next slide, please. Next slide. Okay, so I think there's some familiarity with the Patients First Act and kind of how we got here, but just so that everyone has a baseline understanding, I kind of wanted to provide the background, the history of the programs, and how we got to where we are today. So to better meet the healthcare needs of Georgia citizens, Governor Brian Kemp has obviously taken numerous steps to increase access to quality and affordable healthcare coverage over the course of his administration since 2019. And there's really no initiative that better exemplifies this than and the governor's commitment to these goals than the Patients First Act. The Patients First Act was passed overwhelmingly in the Georgia General Assembly in 2019. And this legislation authorized the state of Georgia to apply for and seek approval for 2 waivers from the federal government to help increase health coverage to lower income Georgians and Georgians of all income levels experiencing challenges with accessing affordable health care on the individual marketplace. These 2 waivers include a state waiver for the Medicaid program, Georgia Pathways, and then also a waiver for related to the individual marketplace known as Georgia Access. And it's very important to recognize Georgia Pathways and Georgia Access work together. They work in concert to provide coverage options to give Georgians more opportunity to gain quality healthcare coverage and access to healthcare services. So they're really meant to work together. That was the vision and the intent back in 2019 when the Patients First Act was drafted. So going through the slide and that you see here, the Patients First Act was, like I said, was introduced and passed, signed into law in the 2019 legislative session. It was carried by Senator Blake Tillery, Senate Bill 106. And then signed into law, at the end of that session or on March 27th, 2019. And like I said, it granted the state the authority to submit a Section 1115 waiver to Centers for Medicare and Medicaid Services, CMS, and then also granted the governor the authority to submit one or more Section 1332 innovation waivers to the federal HHS and the Treasury. And Section 1332 waivers are applicable to the Affordable Care Act and are targeted towards the individual marketplace. Like I said, the 1115 waivers are waivers to the Social Security Act, which governs the Medicaid program. Going through some more specifics, so you see that the deadline requirement, those waivers were actually submitted in late 2019. So the 1115 waiver and the 1332 waiver were both submitted in 2019 and then approved in the fall of 2020. In October of that year were approved by CMS. And so we'll go into this in detail in a minute more when I talk about the different coverage options in Georgia and the requirements of the program. But the 1115 waiver allowed Georgia to increase Medicaid eligibility to a maximum of 100% of the federal poverty level. And so, that allowed us, to offer coverage options to Georgians who don't otherwise qualify for traditional Medicaid and are between the ages of 19 to 64. Also, gave the department the authority to implement the 1115 waiver, which we have done. And then the 1332 waiver had to be submitted, by December 2021, although that was submitted much earlier. And it has led to the establishment of a reinsurance program, and then later on the establishment of a state-based exchange, which was actually authorized through legislation during the 2023 legislative session, Senate Bill 65, authored by Senator Ben Watson. And that was approved during that session. Important to note, the reinsurance program has been live and active since plan year 2022. The health insurance marketplace operates on a calendar year, so that's been in place since 2022. And the state-based exchange was actually just recently, last month, approved for plan year 2025, which will be open enrollment this year, 2024. So Georgians will use the state-based exchange and that state process to enroll in marketplace plans from November 1st. Is when open enrollment opens and then closes on January 15th, January 16th in that time frame. Really talking more about these two waivers before we get into healthcare coverage options, how they work together, and kind of what we've seen, the progress we've seen over the last several years. So like I said, Georgia Access provides for the reinsurance program, and this has lowered premiums for individuals shopping for individual marketplace coverage, and also later led to the establishment of the state-based exchange, allowed Georgia to join over 20 other states, 24 states, and establishing state-based exchange and taking those enrollment functions, the outreach that's involved in marketing plans to that the government spends to try to reach individuals, and taking that enrollment process, the technology surrounding that, from the federal level to the state level. Like I said, OCI just got approval for that for the next plan year. And then Pathways is a new category of Medicaid coverage for Georgians, low-income Georgians who meet qualifying activities between the ages of 19 to 64. The 100% of the federal poverty level, just to give you an idea, and you'll see on the next slides what that looks like. It's about $15,060 for an individual this year and $25,820 for a family of three. And Pathways is targeting those individuals who are not otherwise eligible for traditional Medicaid and perform 80 hours of qualifying activities a month. And it's important to note, it's expected that as a Pathways member's financial circumstances and income increase and improve through the free healthcare coverage that Georgia Pathways through the Medicaid program offers, the individual will then be able to transition to either employer-sponsored insurance, which is commercial insurance offered through employers, or gain coverage through Georgia Access, which is commercial insurance offered through the individual marketplace. So in 2024, that's the Pathways side of it. So on the Access side, in 2024, Georgia has achieved record enrollment for the number of individuals who selected Georgia Access marketplace plans for plan year 2024. 1.3 million individuals selected plans on Georgia Access. Just for a little context, and we'll see the uninsured numbers that kind of reflect this over the last couple of years. When Governor Kemp first took office in 2019, the enrollment in the individual marketplace was 458,000 individuals. So that is a significant increase over the last several years. That the waiver has been in operation, the reinsurance program has been in operation. The Department of Insurance has taken more involvement and ownership in marketing, and their marketing and outreach dollars in the state budget to help accomplish that. And additionally, through the reinsurance program, premiums have been reduced 11% statewide. This represents an average annual premium reduction of almost $930 million. In rural counties where premium prices have historically been the highest, and you've seen the highest uninsured rate, Georgia Access through the reinsurance program has helped reduce premiums by 29%. So some incredible gains made through the last several years. The number of carriers has also increased in the individual marketplace. So when Governor Kemp took office in 2019, we were at 4 carriers as a state. We're now at 10. So the lower premiums and being able to offer those and help pay a portion of the high cost claims that reinsurance offers to carriers makes it more affordable for them to offer plans in Georgia. And so that number has increased significantly. Also, how this looks geographically. So there were fewer options in rural Georgia. It was because it was very, very expensive for these plans to operate there, and they weren't it was not sustainable, for them. But in 2019, no counties in Georgia had more than 2 health insurance carriers. And then now in 2024, 87% of Georgia counties have 3 or more carriers. So significant competition and more options for Georgians, which helps lower costs. Also important to note, as I mentioned earlier, of the 1.3 million individuals who have selected plans for Georgia Access in plan year 2024, 54%, 709,000 individuals, are between 100 and 138% of the FPL. So Georgia Pathways, like I said, provides coverage for those individuals up to 100% of the FPL who are 19 to 64. And then, keeping in mind that Georgia has a record low unemployment rate of 3.4%. More people are working. It's a strong economic climate. A vast number of people are earning higher incomes and are on the marketplace. And that is, reflected in the significant growth in the individual marketplace, the high enrollment that we've seen in the marketplace, but just not the marketplace overall. Also looking at the low income individuals on the marketplace, but under 150% FPL, under 138%. There's 709,000 individuals between 100 and 138, and then there's another 124,000 between 138 and 150, which makes up 64% of the marketplace. Among all states, I think this is an important statistic. Among all states, Georgia has the 4th highest enrollment for any individual marketplace in the country. We're only behind Florida, Texas, and California. So Georgia is clearly a national leader in our enrollment and the number, offering private insurance and commercial insurance to individuals. So clearly one of the leaders in the country, given the high enrollment in Georgia Access in our marketplace. So really just want to emphasize Georgia Pathways, Georgia Access. They're both valuable coverage options within our continuum of healthcare coverage and options. Sometimes focus gets placed on one program, but really all of these programs work together. The two that I mentioned with Pathways and Access, and then Medicare is also a valuable coverage option for Georgians 65 and older. You also have employer-sponsored plans, which are governed by ERISA. And ERISA, the state does not regulate those plans. We don't have as much data on those plans. So I can't tell you all the enrollment numbers specifically, but a lot of Georgians are being served under ERISA plans through employer plans, which is reflected because of our 3.4% unemployment rate. Also, all those programs. Yes.
Sorry to interrupt. Dr. Hyman has a question, I think, maybe before we move off this slide.
Thank you very much. I actually have more of a comment than a question, and I really appreciate the significant success we've had this past year in getting people signed up on individual plans on the health insurance marketplace. But I think that context and history is really important, and I think we can't yet celebrate the success of Georgia Access because we're just launching it now. People that signed up this past year signed up on healthcare.gov. So while General King shared the significant and important efforts made at outreach, and obviously the federal funding supporting navigators and extending the sign-up period were also important. I think it's important to say that, in fact, we don't know what Georgia Access is going to look like in terms of sign-up because we've never done it before. It's all been on healthcare.gov to date. I think the other thing that's critical context for people to understand is that on average, as a result of the Inflation Reduction Act passed during the pandemic, premiums in the health insurance marketplace are down 44%. That sunsets the end of 2025. So again, it's no surprise that nationally, and I appreciate that Georgia's numbers are better because low-income Georgians have few other options, that the number of people signing up has increased dramatically. But I think we who are tasked with planning forward need to understand the context, particularly in regard to just now launching this state-based exchange, in spite of our success with healthcare.gov and the uncertainty related to the potential loss of the increased federal subsidies.
Thanks, Dr. Hyman. I think those are fair comments. I mean, certainly, I think many of us, and we'll get into that at some later point around the federal tax subsidies and the implications that those could have for Georgians. I think Grant's fully aware of that, and we've had some early conversations about what those efforts entail and what possibilities lie in the future. One thing I do want to point out, and I don't know, Grant, if you touched on this yet or not, but a lot of times when we talk about Georgia Access, I think one of the things that we do have some outcomes measures and some information on already is the reinsurance program, which is part of that suite of waivers that has played a pretty significant role in the insurance landscape in Georgia, which he hinted at, but all very valid points and help set the context, I think, for where we're headed next in this conversation.
Thank you. And there's also research on the impact of the 1332 I'd be happy to share.
Sure.
Yeah, thank you for those comments. Really appreciate it. Chair Noggle, just building off of what you said, totally understand, the reinsurance program was active in 2022. So that has had several years, as Chair Noggle said. And also, I would say that the marketing and outreach dollars behind Georgia Access that the state has specifically done on outreach have been, in operation for the last 2 budget cycles. And then lastly, with the, enrollment in the marketplace, again, Georgia is, 4th in the country. So clearly there's been some tailored policy decisions and initiatives within the state of Georgia that, have led to us performing, beyond, the number of individuals within our population. We're the 8th most populous state, and we've got the 4th highest enrollment in the marketplace. So just wanted to note those points as well. But moving on to the next slide. So this provides commission members with an overview of the health insurance coverage options within the state of Georgia. As I've gone over previously, we have traditional Medicaid coverage, which, like many other states, or all other states, all 50 states have a Medicaid program. The medical assistance program provides healthcare coverage to Georgians who meet that specific eligibility criteria, including income and resource limits. A couple examples of groups that are within this traditional Medicaid coverage population include pregnant women, children under the age of 19, individuals 65 and older, a lot of dual eligible individuals there who also have Medicare, who are also pays for nursing home, individuals receiving nursing home care, the legally blind, individuals with disabilities, and parent caretakers with children under 19. So then the Georgia Pathways program, which was launched in July of 2023. Like I said earlier, Georgia Pathways is a new category of Medicaid for individuals, low-income Georgians who meet qualifying activity requirements and would not otherwise be eligible for traditional Medicaid, which we just went over. A couple of the points, eligibility requirements: individuals must be 19 to 64, have household income of up to 100% of the federal poverty level. And gave those 2 examples previously. You can see the dollar amounts because, obviously federal poverty levels, very technical term, policy focused term, but what that looks like in actual dollars, there are 2 examples of based on household size and, what the income dollar amounts are associated with that. Then, of course, completing at least 80 hours of qualifying activities per month. Georgia Access is the other program. And again, this is the state's program for Georgians who shop and enroll in private health insurance plans. Georgia Access is available to all Georgians, and we'll go over the kind of the marketplace enrollment income eligibility categories, kind of where the enrollment within Georgia Access falls, based on individuals' income, where they are above the federal poverty level. But Georgia Access is for anyone. Really, any Georgian can, get insurance on Georgia Access, but specifically it's intended for individuals with household income above 100% of the federal poverty level, and do not qualify for any type of Medicaid and do not receive coverage through the employer. And the reason for that 100% of the federal poverty level is because that is when the ACA and the federal law regarding individual marketplace, individuals become eligible for subsidies at 100% of the federal poverty level and up. And currently, we'll go over this in more detail later, but individuals between 100 and 150% of the federal poverty level pay $0 in premiums per month. And then it's a scale after that: 150 to 200, 200 to 250. It's a scale of what percentage of your income someone would pay. I think I want to take a moment to talk about, because I didn't really talk about the mechanics of the Georgia Access with the programs, but as was mentioned earlier, consists of 2 components: 1, reinsurance, and 2, the state-based exchange, which will go live open enrollment later this year. Reinsurance is basically insurance for insurance companies. So through a federal state partnership, the government pays a portion of the high cost claims for carriers so that they can keep premiums lower for the entire population. So the way the marketplace enrollment, if you go to buy car insurance as an individual, they're going to look at your driving record. That's not necessarily how it works for how they price and offer health insurance plans on the individual marketplace. It's done through a process called community rating, where they take, age, geography, and they, price their plans that way and charge everyone in that category the same price, versus looking at an individual's health status and charging you based on your risk a higher amount or a lower amount. So that's how that program works. And then, of course, the state-based exchange transitioned us from the healthcare.gov platform to our own state-based platform, and also gave us more direction and oversight of the outreach dollars that go towards helping make individuals aware of health insurance coverage options. Another important point about Georgia Access in the marketplace is, individuals can enroll through multiple points of different entry. They can enroll through web brokers, carriers directly, agents, or on the website, which will be georgiaaccess.gov. So they really have several different ways that they can enroll versus just going to one site specifically, which really helps with a lot of the outreach that's done and helps individuals have a more seamless process to enroll. And also those different entities in the private sector, they also spend a lot of money themselves on marketing, outreach, trying to reach individuals who may qualify. Also want to mention that there has been a special enrollment process in effect since 2022 for the individual market for individuals between 100 and 150% FPL. So they can enroll at any time. Usually there has to be a qualifying event for someone to enroll outside of the open enrollment period, which is traditionally November to January. But if you are between 100 and 150% FPL, you can enroll at any time in marketplace coverage since 2022. Next slide, please. Next slide. So 2017 uninsured population data. Why are we showing 2017 on this slide deck? Well, that's because, again, like I mentioned previously, uninsured data, American Community Survey data, operates on a two-year lag or a lag of some sort, depending on when it is in the year. So in 2019, when the Georgia Pathways and Georgia Access waivers were developed, the state was using 2017 census data to help inform that. Just like now in 2024, we are using 2022 data to help us understand the lay of the land for uninsured data in Georgia. At the time, 2017 census data, again, what we were looking at in 2019, over 1.4 million Georgians, 14.9% were uninsured, and the largest percentage of those were individuals, of which 478,000 were under 100% FPL. And then what I meant to say, the largest group of uninsured Georgians with under that 100% FPL was individuals between the ages of 19 and 64. So that, for the uninsured rate for individuals under 100% FPL is further broken down. On the left-hand side, you can see children under 19, there were 66,000 uninsured. Individuals between 19 to 64 was by far the highest at 408,000. And then 65 and over was 3,600 approximately. And so the individuals over 65, as you can read, they're potentially eligible for traditional Medicaid and or Medicare. So Those are coverage options that have existed for a long time. That is why that number is so low. Same thing on the under 19 Medicaid and the Children's Health Insurance Program, which is Peach Care for Kids in Georgia, are available for children under 19, have very generous eligibility parameters. So that is also why that is significantly low. A lot of those individuals, for whatever reason, may not have applied, signed up and enrolled for whatever reason. Just because there is a program offered does not mean that there's 100% uptake. There's always going to be people who do not apply for and enroll in health insurance coverage despite it being offered to them for whatever reason that may be. Then on the right, you can kind of see the whole income, the distribution of uninsured information by different income category. Again, that below 100% FPL. And then on the marketplace, so once you get to potentially marketplace eligible, starting at 100% FPL and up, you see, those are all individuals who qualify, could potentially qualify for, subsidies on the marketplace. Next slide, please. So again, this is the same data, or this is the same format for 2 years later. So this is 2019 data. This is what actually was the info in 2019 when Pathways and Access were being developed, but didn't have access to it at the time in 2019, given the lag that there is in census data. So this is what the data actually was. Again, you can see for almost all categories, better scenarios, the total number of uninsured was 1.3 million, 13.4% uninsured in Georgia. And then again, you can see kind of on that left-hand side that the number of uninsured under 19 goes down. The number of uninsured 19 to 64 goes down significantly. From 408,000 to 290,000. And then again, you see on the right-hand side, the distribution for, marketplace, uninsured, and enrollment. Okay, next slide, please. So this is the real, I guess, the most recent up-to-date data that we have because of that delay in census data for the uninsured population in Georgia. So we're in 2024. This is 2022, but it's the most recent we have. But keep in mind that it's not the actual picture in Georgia is not going to be this because things have changed over the last 2 years. So you can see under 19 has gone down again, 37,000. Again, Medicaid and CHIP have very generous eligibility parameters for children. So again, it's a matter of trying to reach those people and get them enrolled. 65 and older, again, that's your Medicare eligible population. I do want to focus in on the 240,000. So that 19 to 64, 240,000 is individuals who are under 100% of the FPL between ages 19 and 64. That is our Pathways target population. That is who the Pathways program is trying to reach. That is, the maximum that would be eligible for the program. But also keep in mind that this is just looking at age and income parameters. So these individuals could also qualify for traditional Medicaid as well. Could be traditional Medicaid or Pathways, but regardless, we want to try to reach them and inform them of programs that are available to Georgians. And, we are doing that through a marketing and outreach campaign that started in early August to make Georgians aware of Pathways. And then even if we get people who apply for Pathways who through applying for Medicaid, because Medicaid or Pathways is the last category of assistance on the Medicaid eligibility cascade, they fall into traditional Medicaid instead of Pathways. That's great too. We just want people covered, and the goal is to just have people enrolled in a health insurance, health coverage program that they qualify for. So again, that 240,000 is people eligible for traditional Medicaid or Pathways. And I want to emphasize, there's been some reports have shown this number to be other, I've seen 290,000, I've seen, others, but just want to emphasize that this 240,000 is what we're working off of for individuals who may be eligible for the program and who may be eligible for Pathways or traditional Medicaid. Then on the right-hand side, we see the number of uninsured as a whole, holistically. So again, you see that 280 for under 100% FPL. Once you take out the under 19 and 65, that's how we got to the 240 to look at people potentially eligible for traditional Medicaid and Pathways. Then if you get to potentially Marketplace eligible, you see individuals who are uninsured who would qualify for Marketplace coverage and Marketplace plans. And also most of those people will have, be able to access subsidies. So that 100 to 137% pays $0 in premiums. The 138 to 399%, it will vary based on a sliding scale. And then above 399%, no one pays more than 8.5% of their income in premiums because of those subsidies that are available. So of the 1.2 million uninsured in Georgia, there are approximately not over 963,000 of those individuals qualify for Marketplace plans. And again, this is 22 data, not present day. We've seen huge enrollment increase in 2024 who qualify for Marketplace plans. But again, it's that dynamic of just because a program's available doesn't necessarily mean individuals will apply and enroll. So that's important to note that of the 1.2 million uninsured, 963,000 are Marketplace eligible for Marketplace plans.
Grant,
Next
can you take a
slide,
question?
please. Yes.
Christy.
Hey, thanks so much, Kaylee. And thank you, Grant. It's good to see you. Just a couple clarifying questions, and it's about the interplay between traditional Medicaid and Pathways and Georgia Access. Let me just name both of them. They're related, I think. My big question is about people experience income fluctuations all the time, of course. So somebody might be under 100% of the federal poverty level 1 month, 1 year, and then the next one, they're in that 100 or 138. So anything on how we handle fluctuation between the programs and transitions between the programs? And then also just curious right now, if Access does or has plans to screen for Medicaid eligibility. So if you went to Georgia Access, would it tell you if you're eligible for something different? Thank you.
Yes. So yes, I'll start with your second question first. So yes, the Georgia Access, it does have a, Medicaid eligibility engine built into it. So when they're doing their assessment and taking in, an individual's information, they will make a determination if that person is under 100% FPL and say, okay, you're going to pay the full dollar amount, but you're potentially Medicaid eligible. So then they will send that person a notice and send an electronic referral transfer over to Georgia Medicaid to let us know about that person. And so that individual is informed that they could potentially qualify for Medicaid. And they do have a MAGI eligibility rules engine within the SBE that can make that determination and make that referral and recommendation to Georgia Medicaid, where that person, has to go through that eligibility process. On your question about the, back and forth and how things change, there is communication between, both programs. And how they communicate with each other. Like I said, if someone applies and is under income, or someone becomes over income or is under income, they can go back and forth. That information is sent to Medicaid, or Medicaid, if the person's on Medicaid and becomes over income for Medicaid, we will send that referral over to Georgia Access, and then that individual also gets a notice from the state that, informs them of why they, no longer qualify for Medicaid, and that Georgia Access is an option. It will include contact information for Georgia Access, and how that occurs. So that is happening. That communication is happening, but, we've seen it through Medicaid and the Pathways program, people who, if there's, given that it's an integrated eligibility system, there's other programs within the Gateway IES system. The state gets information on someone's SNAP TANF. That's going to also be inform their Medicaid eligibility. And so we have people going from Pathways to traditional Medicaid, which is internal Medicaid transfer. You've got people who are referred from Medicaid to Georgia Access. We want to make sure that's a seamless process for those individuals.
Dr. Hyman, did you have a question or comment?
Yeah, thank you. A couple questions and just really clarification. So Georgia Pathways, you said the target population is the 240,485 that are in that 19 to 64 age group. And I know that was launched in July 2023. And last numbers I've seen, there are about 4,300 who have signed up. So I'm wondering, given that that's, by my calculations, less than 2% of the population that's in that coverage gap, what your goals are now that maybe DCH has broader bandwidth and opportunity to focus on that. So that's question one. And then my second question is, it always concerns me to see the number of children under age 19 that are eligible but unenrolled. And I through a public health lens, I consider that a collective failure. So I'm wondering what thoughts you and colleagues have about opportunities to either reduce administrative burden or otherwise engage that population. And I know that other states have tried strategies related to auto enrollment or continuous enrollment for children between ages 0 to 3 or 0 to 5, and just wondered what your thoughts and or strategies were in terms of thinking about that population.
I think that's a fair question, but Dr. Hyman, if you don't mind, Grant, I may ask you to hold that one till the end, because
Okay.
I've had the benefit of a pre-read of the slides. I don't want to get us too far down a different rabbit hole, because I think we could spend a minute on that. And I do think there are some potential policy levers that other states have engaged around continuous eligibility for children under 5. And there's some new ones related to CHIP and some things like that I think might be worth talking about. But, and I also know, I think Grant may address some of your questions on what are we going to do to target the 240 in Pathways. I think in a couple of slides or towards the end, kind of with maybe Grant, you can touch on DCHs and the governor's plans on how you're using marketing dollars to go get them. But I might have you hold those just for a minute so you can get through these data heavy slides.
Yeah, that's perfect. Just let me know when to address them once we move on. Okay, I think we can go to the next slide now. So again, given the interplay between Pathways and Georgia Access, wanted to provide this enrollment data for 2024. So like I said, there are currently 1.3 million Georgians receiving marketplace coverage. 96% of those are receiving financial assistance. Consumers between 100% FPL and 150% FPL are eligible for zero premium, a silver plan on the marketplace. You can see that breakdown in the chart on the right hand side. Also, I've mentioned this, but we'll also note that it's critical to understand too that for individuals between 100 and 150% FPL, those individuals have a special enrollment period that has existed since 2022. They can enroll at any time. Don't have to have a qualifying event. So especially important, just for that population, I think it's also reflected in some of the numbers we see with the enrollment data that's so high. So these are numbers here as of January 2024. But keep in mind that because of that special enrollment period, and then just those individuals, not as large of a group, but individuals who do have qualifying events, that number could be increasing every month. Every month there could be more people coming on to Georgia Access because of that special enrollment period. As you can see here, again, just want to highlight the 100 to 138 population. It makes up 54% of the marketplace, 709,000 individuals. Those individuals are paying $0 in premiums, as are the individuals between 138 and 150. So that when you add those, it's 64% of the marketplace. And then also very generous subsidies for premiums for the rest of the population within the marketplace. So you look at 150 to 200% FPL being between paying, that means they pay no more than 0 to 2% of their total income in premiums. 200 to 250 pay no more than 2 to 4% of their income. 250 to 300 pay no more than 4 to 6%. 300 to 304 to 400%, no more than 6 to 6.5% in income. And then for anyone over 400% FPL, no more than 8.5% in income. Just wanted to show that to everyone so that, and again, this is on the one pager that was sent out previously. So we can go to the next slide. Next slide, please. Yeah.
Can I chime in real quickly, and just for the sake of the commission members and others, couple of data points that I want to reiterate and just maybe even ask Christy or some other folks for some help, maybe just thinking through. And Grant, just kind of a tangent for a second, follow along with me, I think. So Lynette previously in our last meeting, I think reported data that there are roughly 2.6 million Medicaid members currently and change. I think your slides today, Grant, showed that there are 1.3 million Georgians on exchange plans and change. I have some information, and I've actually asked them to pull some others, but AHIP, the American Association of Health Insurance Plans, publishes some data specific to Georgia. And as of 2024, they're reporting that there are 5.12 million Georgians covered by employer-sponsored insurance. And then backing out of that, what Grant's showing here is uninsured. We know population in Georgia is just shy of 11 million, 10.91-ish. I think the number I'm missing, I'm trying to find out is, I think our Medicare enrollment non-duals, right? So that they're not double counted, but pretty closely trying to get us to, been searching for the right data source to get us to this, that some of you has to ask me about the entire pie chart of Georgia and how people are covered, and what we're really talking about in terms of the pieces of the pies that this commission is focused on. And Christy, do those numbers sound right-ish to you?
Oh man, off the top of my head, I was trying to note down.
Well, we can vet them later. So I mean, Grant's numbers 1305 on the exchange is coming from CMS data files. Medicaid, Lynette reported from their data 2.6 this year, which is a little bit down from last year, as we knew it would be. Publicly reporting from AHIP is 5.12. So that's starting to make up the total of our 10.91 million Georgians. And so that number of 240 or 280,500 essentially under 100% FPL, some number under 19 to Dr. Hyman's point that could be eligible, children could be eligible for Medicaid, unknown reasons potentially why they're not enrolled. And we can certainly talk about those. And then 2,700 potentially eligible for Medicaid or Medicare, ABD of some sort. But so I guess the population we're really honing in on is this 240,000 that's uninsured and could be eligible for pathways or Medicaid, I guess.
Yeah, I think, Haley, part of the gap has to be because we don't have those uninsured numbers yet for 2024 and the movement off of Medicaid. And obviously the ACS, when we get those numbers for 2023 later this fall, will get us the 2023 uninsured. But I think we can do some work I certainly think we can do some more work to
Swap
try to bring
numbers.
this
I
down
think-
and I can think of a few different places, sources that we
These
could.
ranges. I think it's close.
Yeah.
I mean, Lynette reported last time, and I think there's federal CMS reporting, Grant, from I'm wrong, that shows from redeterminations the number that got picked back up somewhere else. I feel like where my number is off is on the Medicare, that I've got Medicare, but I don't have non-duals. I think my Medicare number might be overinflated because currently I have more people than we have in Georgia. So we can continue to work on that, but for the sake of the whole commission, just know that that's a graph I'm trying to put together and have called upon a couple of folks to help me through that. But sorry, Grant, I needed to go down that rabbit hole just a minute and make sure that we were all kind of on the same page, that 240 number is really where we're honing in on for pathways and what our current waiver is intended to target, I think. So I'll turn it back to you.
Absolutely.
Sorry.
Yep. We can go to the next slide. Yeah, this one, the timeline slide. So just wanted to give everyone Dr. Hyman, this will address part of what you asked. So this will addresses the timeline of the Georgia Pathways program. So already been over some of this, but December 23rd, 2019 is when we applied for the 1115 waiver. We were granted approval by CMS in October of 2020. Then, we had an original planned implementation date of July 1, 2021. That did not happen. We were not, given approval to move forward with that. At the time, there were discussions back and forth with CMS over some different objections, changes that they wanted after their approval. And then in on December 23rd, 2021, CMS rescinded approval of the original waiver as it was approved. And then Georgia filed suit in January of 2022. U.S. District Court ruled in the state of Georgia's favor in that lawsuit against CMS and reinstated the waiver in August of 2022. However, there was then after that some ramp up time that was required since the waiver had not been being implemented or worked on from that time when the approval was rescinded in December 2021 to August of 2022. So there was some ramp up time that was required to get our contractors back in place, get systems set up and ready to go to start to launch this new eligibility category within Medicaid. And then, after that ramp up period, we went live with the program on July 1st, 2023. I will note, you see at the top, it says 2-year loss. So the waiver was approved for 5 years. We were given approval for 5 years, and it was intended to launch on July 1st, 2021. But because of that lawsuit and because of that delay that we had to take to court, the program did not launch until 2 years later, July 1st, 2023. And, not only is it a 2-year delay, but the delay had a lot of significance and importance given what was going on in the world and in Medicaid during that time frame. The federal government directed states to begin Medicaid redeterminations and Medicaid eligibility determinations starting in April of 2023. So you can see that noted on the timeline at the bottom. April 1st, 2023, PHE unwind begins. And then, we completed the initial cohort, everyone who was on Medicaid prior to, the predeterminations process beginning, through the PHE, because we were not allowed to, the state was not allowed, no states were allowed to disenroll anyone from Medicaid unless the member disenrolled voluntarily during that period of the public health emergency during COVID-19, which took place from about March of 2020 all the way to April 1st, 2023. So that is significant in how it relates to the Pathways program because had the waiver launched, had Pathways launched July 1st of 2021, at that time, the state was not doing any renewal cases. We were not working renewal cases. But fast forward to July 1st, 2023, that's only 3 months into Medicaid redeterminations. And then, we're having to work renewals and redeterminations for all 2.6 million Georgians on Medicaid. We're having to do new applications, we're having to do changes versus if the program had launched July 1st, 2021, we wouldn't have been doing any renewals. It would just be working new apps and changes. So that's a significant, not only 2-year loss, but also when you add the context of what the significant casework and workload that the state had to do in July 1, 2023 versus July 1 of 2021 due to redeterminations, especially launching a new program, which requires a lot of bandwidth to get off the ground. And when you're trying to market and outreach and do all those activities. And then also the last thing on here, January 6, 2024, the mandatory HIP program goes live within Pathways. HIP is just is a program within Medicaid and also within Pathways that if an individual applies for Medicaid and it's determined that they through third party liability or can access insurance through a employer, if it's financially advantageous to the state will pay the premiums or the cost sharing that's involved for that individual to be on that private plan instead of them being enrolled in Medicaid, but the state is still paying. So that's what that is. I know we've got some, I think we saw in the chat here that Medicaid CHIP enrollment as of July 31st is 2,263,236. So I think it was higher, closer to 2.6 or 2.8 during the but prior to the PHE and the unwinding. But current enrollment as of July 31st is 2.2, a little over 2.2 million. And then Chair Noggle, to answer your question about the individuals who transitioned from Medicaid to Marketplace, that is CMS data that's publicly available. There are 400,000 Marketplace consumers who are on Medicaid as of April 1st, 2023 or after, who were either on Medicaid at that time or gained Medicaid sometime after that redeterminations and then came off and went to Marketplace. There's 400,000 Marketplace consumers, 350,000 of which are QH. They were approved for a QHP, a qualified health plan, what we call the Marketplace plans, within the Marketplace. Next slide, please. So here are the goals of the Pathways of the Georgia Pathways waiver. These goals are stated as part of our 1115 waiver. Within the waiver that was approved by CMS, the goals are to improve access, affordability, and quality of healthcare in Georgia with strategies to improve health of low-income Georgians by increasing access to affordable health coverage, by encouraging work and other employment-related activities. I'll go over what those activities involve on next slides. Reducing the number of uninsured Georgians, promoting member transition to commercial health insurance. Again, we talked about the interplay that exists between Medicaid Pathways and Georgia Access. So the goal is to give them a place when they're at that income level to have healthcare coverage and then ultimately transition onto commercial health insurance and Georgia Access or an employer-sponsored plan. Empower Georgia Pathways participants to be active participants and consumers of their healthcare support newly eligible member enrollment, employer-sponsored insurance, like I talked about, increase the number of persons who become employed, increase wage growth. That's part of, as wage growth increases, eligibility for commercial plans increases, and they can become eligible for those. And then ensuring the long-term fiscal sustainability of the Medicaid program. Next slide, please. So we've been over this information. I won't repeat it all again, but again, here on the slides, you see, the general criteria for pathways eligibility is listed out here, and been over that previously, and launched on July 1st, 2023, as we discussed. Next slide. So Pathways applicants, verify that they are completing 80 hours a month of qualifying activities. Their members can engage in one activity for 80 hours a month to meet this requirement, or they can engage in a combination of activities per month in order to meet this requirement. And it's not just working or employment, also on-the-job training, job readiness assistance, community service, higher education through enrollment in both public and private universities and technical colleges. So we've been working with USG, TCSG, doing outreach to universities, to colleges, private colleges, to make sure students are aware of this program, that if they're uninsured, free health insurance option. And then participation with the Georgia Vocational Rehabilitation Agency, GVRA, also qualifying activity. And then you see here reasonable modifications are available for individuals who, have a disability. It gives them up to 90 days to, enroll in a GVRA program if they need that option. Next slide, please. And then the Pathways benefit package includes almost all of the services covered in traditional Medicaid: doctor visits, hospital stays, emergency services, prescriptions, laboratory and x-rays, family planning, home health, preventative and wellness, chronic disease management. I don't see mental health services on here, but that is also included. So that same benefit package that is available in traditional Medicaid is also available here, with the exception of non-emergency medical transportation and EMT. Next slide, please. So thank you. That wraps up the slides and the content core of the presentation. Do just want to address one more thing that Chair Nagel mentioned. The state has initiated a significant and comprehensive marketing and outreach campaign where we are intending to reach Georgians who may be eligible for pathways. And so that consists of marketing, ads, dollars that are going to ads on social media, ads on Meta, search engine optimization, streaming to where all those paid advertising opportunities, and then also a comprehensive and robust outreach campaign that involves working with organizations all across the state to inform them about Pathways, this new Medicaid eligibility category that individuals they interact with and serve may be eligible for. I'll give some examples of those: healthcare providers and associations. So we've been working with healthcare associations and individual hospitals and providers to give them this information. Any uninsured Georgians who they may be interacting with, or who may seek services from them as a provider, they can inform them of this option. We're also reaching out to, as I said, USG, TCSG, the private colleges, anyone who's enrolled in higher education. We want them to be aware of this program. Not everyone, many students are not on their parents' health insurance plan. They may not have that opportunity, and Pathways provides a great opportunity for them to get free health coverage. And they're doing their qualifying activities because they're enrolled in higher education. Some are working part-time. We're also working with organizations in the community like YMCA, those types of community-based organizations, United Way, different volunteer and community service-related organizations. If they are working with people doing community service, they could be eligible for, the program if they're uninsured, given that, they're doing community service. So we're working with a a lot of different groups like that, and also attending events across the state, events in communities, to have a Pathways presence to let them know about this healthcare coverage option that is available to them. So I know we probably have questions, and Chair Noggle, I will turn it back over to you.
Thanks, Grant. Real quick, I do think you might get a couple questions. I'm going to circle you back to Dr. Hyman's question for just a moment on children under 19, and you may or may not be the one to answer this from DCH, but I do think there are a couple of things that we could talk about that the state has moved us towards, or maybe other opportunities to continue building on some recent wins around express lane eligibility, presumptive eligibility, and maybe continuous enrollment for children. I don't know your kind of personal experience or ability to respond to that, or if that's something better answered or addressed to another member at DCH, but anything you want to chime in there, or any other opportunities where you feel like we might want to spend some time in specific to children.
Yeah, absolutely. Well, thank you for that question. I can talk about some of those things. So you referenced a couple of the things that the state is doing. Continuous enrollment did go live for children for 12 months of continuous eligibility and enrollment. So starting in January of 2024, children on our Medicaid and CHIP program get 12 months of continuous coverage. And you may say 12 months. Well, most Medicaid is renewed 12 months, but Georgia has an integrated eligibility system. So sometimes it happens where, there's information provided to SNAP, TANF, or another program within the IES system, and that, gets applied to, Medicaid. So this is important that even with changes in family income or that FPL percentage, individuals who are under 19 will get that 12 months of continuous coverage. Also, you mentioned express lane eligibility, which is a program that the state has been championing for several years now. Several years ago, there was a legislative effort, and we added SNAP and TANF to express lane eligibility. And then just recently, based on appropriations language in the 2023 budget, added 3 more programs to express lane that are within IES, so WIC, CAPS, and refugee assistance. So all 6 programs within the IES system are now are part of that express lane eligibility, and that basically means that if the state can use information from other programs. So say someone is applying for SNAP, family or for a child, because it's a term of art for children under 19. Express lane eligibility is if they're applying for SNAP and they just applied for SNAP, but our systems and caseworkers can see, oh, well, based on what they submitted, they could also be eligible for Medicaid. They could also be eligible for TANF, and they have an opt-out feature where it says, if we are going to consider your information for enrollment in Medicaid, enrollment in TANF, unless you click here to opt out. And so we added those 3 additional programs earlier this year. So now the whole system is running on express lane eligibility. And we also changed it from an opt-in to an opt-out program so that we could hopefully capture more people that way, because people are more likely to participate if it's opt-out versus opt-in. So those are several different initiatives. And then I think just generally, like I said earlier, there's no state in the country that has a 0% uninsured rate. And that's because, even though programs are offered, there are coverage programs offered, there will just always be some people who do not apply and enroll in the program. It still requires action on part of the person to consent and to apply for Medicaid or whatever benefit program it is. So there will always probably be some uninsured, or always some uninsured, but our goal is to get everyone covered who may qualify for a program. And I think part of that involves marketing and outreach, and it's part of what we're doing with Pathways to try to do all this outreach with community organizations. And we did it with redeterminations through the Stay Covered campaign in partnership with DHS. There was a big media campaign around that. Just getting the word out both through media and through outreach and organic partnerships, because we need to make people aware of this program and apply. But there's a variety of reasons people may not end up applying, unfortunately. Also, it's reserved for citizens or legal permanent residents. So if someone is not in that category, they would not be able to apply, and they would not be able to obtain coverage. And they would be included in that number because the number that 37,000 is just looking at their age and their income level. So if someone's not a legal permanent resident or a citizen, they wouldn't be eligible, and they're going to stay in that uninsured option based on the requirements of the Medicaid program. And then, some individuals just don't want to submit an application for whatever reason.
I may have a couple more questions for you in a moment, but Dr. Hyman?
Yeah, thanks. Yeah, I was just looking for the answer to the other question that I had asked in regard to the Pathways program. It's my understanding that 13 months in, we're still at about 4,300 that have enrolled. If there's an updated number, I'd love to hear it. But I'm curious. I understand there's $10 million being set aside for marketing and outreach. I'm wondering what your goals are and what your projections are and what success would look like in terms of that program.
Absolutely. So thank you for that question. A couple different points I want to make in response to that. So going back to some of the uninsured data that we looked at on the earlier slides, you can see on the 2017 uninsured data, there were 408,000 individuals within that 19 to 64 potentially eligible for traditional Medicaid or Pathways. That then was reduced in 2019 to 290,000. It has been further reduced since 2019 to currently 240,000 in 2022. And 2022 is not real time, as we talked about. It's 2 years delayed. So you've seen over the last several years that population number for individuals between 19 to 64 and under 100% FPL has consistently declined. So you're seeing there.
But don't we need to acknowledge that there was a public health emergency and no one was disenrolled, so that across the country there was a dramatic drop in the uninsurance rate, and in spite of that, we still have one of the highest uninsurance rates in the country. I mean, we have to contextualize these numbers. We can't claim a state level success for numbers that are a reflection of increased federal subsidies in the marketplace and a public health emergency that prevented us and every other state from disenrolling people. So I appreciate everything you and your colleagues are doing. I appreciate the successes we've had, but let's not claim a state level victory for things that our actions had no impact on.
Dr. Hyman, I don't think we're trying to pass judgment one way or the other on the Pathways program right now. I think what I said in my opening, and I think we'll get there, our job as a commission is to look at future opportunities. One of the things we'll get to that in a minute. As I've said it on record before, this is the program that we currently have in place and that it is an option in Georgia. And I think as healthcare providers, and supporters of healthcare providers across the state, it's prudent on us to do the best we can with the program that we have, while we also look at ways where we can do more. And I think it's not an either or, it's a this and.
I agree completely. I would just like an answer to the question of what a reasonable expectation is, given that 240,000 number that you shared, Grant, for how many people, now that we have the enhanced bandwidth, we're not going through the unwinding process. We have more resources for outreach and marketing. What are your projections for a year from now for the Pathways program? What would success look like to you and your colleagues if we're successful? That's all.
Yes, happy to answer that question. But first, let me answer the question that you originally asked that I did not completely finish. So I gave you and provided you kind of the updated the updated population census data for individuals under 100% FPL between the ages of 19 and 64, how that's declined, over time. So, no one's making judgments either way. I'm just saying it's the statistics show that number has decreased over time. We don't have 23 and 24, but that number has gone from 408,000 to 240,000. So your number of potential eligible based on the most recent data we have has significantly declined. Part of that's attributable to Georgia's economy. Georgia has a 3.4% unemployment rate. That is better than a lot of other states nationally. It's actually one of the best. So that's very important to take into account here, that and you can see it through our marketplace enrollment. The 100 to 138, that's just over that threshold, is 54% of the marketplace. So that's a very important component of what you asked. I think that's part of the answer to your question when you're asking about enrollment, the number of potentially eligible. We didn't launch this program till July 1st of 2023 due to the 2-year delay. And based on 22 census data, that 240 number was reduced from 408,000. Number two, I think, the redeterminations, the 2-year delay that we had due to litigation made a significant impact, because these applications come in and it takes work to process them. People can't become eligible for the program until the application is worked and processed. And given the fact that this program was supposed to launch in July of 21, it did not launch until July of 2023 due to a 2-year delay due to litigation that we ended up, being successful in and getting the waiver reinstated. We lost that 2 years of time. And like I said, we had to launch the program 3 months into redeterminations, when we're having to do a significant number of renewals in addition to new apps, and versus if we had launched 2 years prior, like was originally intended, we would not have had to be doing any renewals at the time. Our caseworkers would have had more capacity, and we would have been able to, process more. So that's another factor. Third factor is, we just, like I said, started a marketing and outreach campaign in August. We are only 1 month into that. So we are working to, actively deploy those media ads, do that marketing and outreach, working with community organizations to do exactly what you're talking about, to make people aware of what they could be eligible for, to encourage enrollment. One of the encouraging things that we've seen through this process is that not only are individuals, who submit a Pathways application, what we define, a complete Pathways application, some of them are falling into Pathways, but also some of those are falling into traditional Medicaid. So someone's submitting and that number is 12,000 applications, 12,000 people, a little over 12,000 people who applied are actually now enrolled in Medicaid, even though they submitted a complete Pathways application. Because like I said, Pathways is the last class of assistance within the Medicaid cascade. So, but they filled out the qualifying hours and everything, but they were determined at the end of the day to be eligible for traditional Medicaid, which is great. Some people were also, denied for income reasons, a lot of people, and they are transferred over to Georgia Access. So there's some nuance there that's important to note. You mentioned, what success, looks like, given that, that number is a moving target, that individuals between 19 to 64 under 100% FPL, we've seen a lot of variation, and very likely that 23 census data will show something different. And that's even different than 24 real time. When we did the waiver analysis back in 2019, when we applied for Pathways and had projections back then, that was based on the census data that was available at the time, which was 2017 data. So we have more, 22 data. It's not, an accurate depiction of, what, it's the most recent data we have, but, we won't have 24 data for a while. So I can't tell you exactly what that number is. We just want to do outreach and conduct marketing and outreach to, Georgians who may qualify at that income and eligibility level, and not just enroll people in Pathways, but all these programs work together. So if our outreach results in people getting approved for and applying for Medicaid and ending up in traditional Medicaid, that's a success. If they apply for and end up being directed to Georgia Access and enroll in the marketplace, that's a success too. It's not, there's a lot of different programs working together here. It's not just you have to look at them holistically and working together, not just one program on its own in isolation you know, an arbitrary, you know, a number.
Thanks, Grant. I'm going to move us on a little bit. I'm going to come back and let you wrap up with a question for me in a bit, but we've got several other of our commission members with questions. And next is Delvecchio Finley.
Sorry, I had to get myself off mute. Thank you, Kaylee. Actually, I think Commissioner Davis was before me. I'm happy to
Go ahead.
go ahead, but
Go ahead,
are
Billy.
you okay? Okay,
Yeah,
thank
yeah.
you so much. I appreciate it. I actually had two questions, but let me first echo my thanks to you, Grant, too. I think the context and the information you've offered is incredibly helpful, just like our your colleague. It's a lot to digest, so I'd love to, you know, be able to synthesize it a little bit more, which I'm sure we'll do. But in a nutshell, I do appreciate that. Actually, where you just left off, there's a constellation of programs and traditional sort of payment or coverages like you know, commercial, employer-based or sponsored coverage, as well as Medicaid. But then these new areas like pathways and access. So that's great. I'm curious about the other side. You talked about the coverage, sort of the elements of the coverage, and you mentioned that I think you said both for pathways and I think for access as well, that the coverage mirrors a lot of what Medicaid offers, including behavioral health. Have you seen any difference in the enrollment of providers in the programs and the various programs? Because, you know, coverage is one thing, and I know we're talking about kind of some of the challenges around coverage, but coverage does not beget access necessarily if people don't have a provider on the other side who's willing to accept it. So I'm curious about that, and then I have a follow-up or a follow-on to that. But if you could ask or share if you know anything about if there's any disparities in I'd say plan participants, if you will, from the provider side in the various programs.
Sorry, I was on mute. You know, very good question. I think, you know, as you look at all these different coverage options, you know, they're definitely different in kind of the provider participation that they have, if you will. You know, typically commercial insurance reimburses the highest. And so, you know, because of that, they usually have larger provider networks and more providers options for the patient. For the provider themselves, they get reimbursed, you know, at a relatively high rate compared to some of these other programs. You know, Medicare is, you know, reimburses closer to cost, so that's less than commercial insurance. Medicaid typically, you know, reimburses the lowest with you know, being a percentage of cost. So, and with that, you know, comes different considerations with provider networks and providers who participate. But definitely appreciate the question and thank you.
Well, you know, thank you. I think that one of the elements is we look for, because I really appreciated 2 points. One that Kaylee distilled, which was, you know, kind of looking at what that number has been, irrespective of kind of how, in terms of the decrease, but the, you know, the kind of empirical number of what we're talking about from the most recent data, irrespective of how it got there. But then, you know, definitely being mindful of what it might be now, which we don't have the most accurate data yet, or updated data, and what it might be in respect to new conditions that we're facing going forward. But then the other part was actually, I think I saw, at least from the data that you shared, of the breakdown of the it was declining, but over 1 million people who were you know, not insured but eligible for certain subsets. The group that was over, I think it was 400% or 399%. That number from 17 going up to 19 and up to 2022, seemed to actually be increasing from like 9% to 11, and I think to like 14%. So if we're looking at it kind of from a, I don't know, philosophical perspective, you're talking about people who, if you just assume are eligible, or say able to afford some level of coverage, but electing not to, then there's about a growing number of that population, which may be reflective of your comment about the improving economy and workforce, that I don't know if it's that the employers don't offer it, or if they're self-employed and they don't get it themselves because they've decided that they would secure healthcare other ways if they needed it. But there's a growing number of people who are in that income bracket who don't have insurance. And I don't know the extent to which, as we look at our work ahead of us, how much of an emphasis that'll be on that or that subset of the uninsured population than it would be on, say, children, which I totally agree with Commissioner Hyman. I think, you know, I would hope, or else in my own perspective as a society, we want to make sure that children have access to care, and we have resources enough to be able to do that, and that we should be doing everything we can to get them covered. And then from the more individuals who have more choice or ability to discern themselves, 1964 and otherwise, looking at the various constellation that we'll get there. So I guess saying that, then my last question, and you sort of alluded to it, was around experience from payment rates, because I think that is a lever that we have to be mindful of. And as we look at these different constellations of programs, not just the coverage and, you know, how much of it is subsidized or not, and how much individuals experience, but on the other side, you know, there's an onus to ensure that the network is adequate enough that people who have the coverage can actually get care, and obviously want people to get care in the lowest cost setting as possible. So it'd be interesting, perhaps, if you could opine a little bit now around from the state perspective for both, particularly for pathways, maybe for access as well. What levers are we using to discern and influence that level of consideration so that these programs do actually materialize in the way that we want, which is people have coverage and they actually secure care, and they can actually get care, I should say.
Yeah, definitely. So appreciate the questions. Yeah, I would say on that, you know, above 399% of the FPL, you know, that population you're talking about. I think one thing that was a positive development was, you know, those individuals above 400% used to get you know, not qualify at all for tax credits to cover portions of their premiums. But then, you know, because of those enhanced subsidies from the federal level, they now pay nobody pays more than 8.5% of their income. So because of that, they should have become more affordable for, you know, individuals, you know, at that income level. In addition to that, you know, with the reinsurance program having been able to have such success in lowering premiums statewide by 11%, in rural Georgia up to 30%, you know, that's going to help those individuals too, because they are, of course, responsible for more of their premiums. So yeah, this is 2022 data. Reinsurance program didn't start until 2022. So still need to see, you know, more recent years data to see developments. And then I think the enhanced subsidies were also a change that took place during that time too. So maybe we don't have quite enough data yet to be able to see if those have worked, but those should have helped address and improve that situation. And then I would say with pathways and Medicaid, to your questions there, you know, we're continuously, you know, evaluating those programs, working on performance management and making sure that, you know, we contract with CMOs, and, you know, those CMOs oversee and administer Medicaid plans for a large portion of our Medicaid population. Pathways population, the children on Medicaid or Peach Care for Kids, pregnant women. So, you know, that we really work closely with them to ensure that, you know, we have adequate provider networks, that, you know, that we have, you know, that provider participation that is needed to make sure that just because somebody has an insurance card or just because someone has a Medicaid plan, that it actually translates into them getting the care that they need and the access to services, which a big part of that is making sure that there's adequate providers, primary care doctors, specialists participating in those networks. So we work very closely with them to ensure that happens.
Okay, and I should just say, as a clarification too, on the exchange to those individual plans, I think also an area that I would encourage focus on, because I think there has been some success on the Medicaid side and various sorts of programs and waivers that help to subsidize the cost of care and there by extension improved access and coverage. On the exchange plans, which would obviously be a lower cost for the state in terms of the coverage, the reimbursement that's given there, it's been my experience, at least on a empirical level, that it's variable by payer and plan, and I think that that's an area of great concern as it pertains to those individuals who are getting coverage there and actually being able to access care, and the providers who are caring for individuals to be able to sustain that access. Thank you.
Thanks, Delvecchio. Christy, and then Dr. Odom will come to you after Christy.
Thanks again. And Chair Nagel, I think these are more just registering ideas for potential topics, particularly as we look forward and as we kind of learn our, do more of this understanding our context. So Grant, perhaps a little break for you in the questions. But just a couple areas that I'm curious about as we think about the systems in this state that support Medicaid and all these insurance programs. So our enrollment systems are, all those kinds of systems, understanding the experience of consumers who are interacting with those systems and whether or not there are any opportunities for streamlining in that regard. And I'd also love to learn more about the experience of our caseworkers or navigators or others who are also trying to help consumers experience those systems. I'm just, curious to learn more about how those are working and whether there's any opportunity there for thinking about, again, streamlining, keeping people insured, transitioning between different types of coverage. So I think that would be helpful. And then, of course, on the financing side, some more understanding about how this is paid for, and the interplay between the state budget, federal dollars, et cetera. So on that piece, and then what different, is it Medicaid, is it Access, whichever, private insurance, what does that mean for the safety net providers on the ground in terms of their reimbursement rates? So looking at hospitals, looking at our FQHC network, et cetera, how does that translate in terms of what's happening when payment then goes to our providers? So just a couple other topics, little tiny topics to put on the list as we get our grounding for the next couple of years. And I know it's going to take us a while to bite all those off.
Yeah, no, I love that. I love some math and some budget, so let's do that. Especially if it talks about reimbursement to hospitals. Delvecchio. Dr. Odom. And he may have trouble, so if I need to relay from a chat, Dr. Odom, I can, but you're up if you can unmute. All right, I'm going to keep watching for Dr. Odom because I know he has a question, but Dr. Odom, if you can hear me, maybe you can type it in the chat and I'll relay it to the group on your behalf, if that'll work for you. Or you can text me. I've got some follow-up and some wrap-up that we need to do as a group a little bit and before we close. But Grant, maybe part of that, can you tell us what's next? So if memory serves, the original Pathways waiver goes through September of 2025. Do y'all have plans yet that you can share on what timeline and next steps look like on what comes next in terms of pathways or opportunity for public comment, or if there would be an opportunity for the commission to provide feedback on what an evolution or a next waiver would look like under the Pathways umbrella? Are we not quite there yet, which I certainly understand, but anything kind of what comes next on that timeline you shared with us?
Absolutely. So great question. We are definitely aware of that. The waiver is in effect until September 30th of 2025. So don't have really specifics to share at this point, but the team is looking at, all options and different options to ensure that we continue this program and ensure that the individuals enrolled in Pathways can continue to have coverage. So we are, evaluating and working through all those options and making those plans. And to your point, in a waiver renewal process, part of that application process, there is a public comment period that is required, that has to be a month long and hold 2 public hearings and all that. So there is certainly the opportunity for the public to review the draft of that renewal application and to submit written and make oral public comments as a part of that process.
Perfect. Any other comments or, hold on, maybe that's some chat. Dr. Hyman, I think we have about 2 to 3 minutes left for questions. I think Dr. Hyman might have 1 or 2 more process related questions. And I don't know if you mean process related to the commission or to Medicaid, but
Yeah, it's related to the commission and candidly, they don't need a response and they're really more for you and my fellow commission members for thinking about. But so one kind of broad question for us all to consider is where are the opportunities for us to open this process that we're in? And I'm talking specifically about opportunities for public input and public comment. And I appreciate that we're now developing an email list so that those who kind of raise their hand and say, I'm interested are informed, but it would be wonderful to be able to outline some avenues for input and comment as we get started, as the process moves forward. So that's kind of comment one, again, for us to think about. The other is, I practiced medicine for 20 years and I'm now a health policy professor. So I am much deeper in the weeds than most of the commission members. I'm wondering where the opportunities are for us to develop a list together of areas for broader commission member education to really understand the landscape. And I appreciate the start that we've had. And I think that's been really valuable and important, but there's obviously a whole universe. Montana has this program called HelpLink, which is specifically designed to connect people who have Medicaid coverage through the expansion they did to jobs. So there are other ways to connect people to jobs other than making it a hurdle for Medicaid. And I guess the last kind of process thing is I really appreciate your leadership, but I feel like it would be nice to have an opportunity to talk across the commission members and develop a collective set of priorities that we think should be kind of front and center as we think and plan forward for possible paths forward for our state. So those are the things I wanted to put out there, and we can process them together whenever you deem appropriate.
You beat me to it, so I'll address a little bit of that in my wrap up today. And we'll get to that in just a moment. But Dr. Odom, I think, is ready to make some comments.
Can you hear me now?
Yes, Dr. Odom.
Oh, good. Might not can understand me. I've got some problems. I agree with Dr. Hyman 100%. I do think that we need to start doing a little bit more brainstorming. I also think that, and I don't mean to be malicious or come off as trite, but most of you guys are in Atlanta and I'm down here in the jungle. My uninsured rates are higher. My patients don't sit around entering their data into computers because they don't have one. This isn't going to work, at least what we discussed today, unless there's boots on the ground enrolling these people. It's just simply not going to work. Apathy, social determinants of healthcare are extremely important when you're dealing with this population. We have to have our free clinics. We have to have our social workers. We have to have our for-profit hospitals who are losing money helping us get these people signed up. I also agree with Dr. Hyman that this is a crisis. We have not just the insurance problem and being in the top 5% of the uninsured in this whole country. We're also in the top 5 of access to health care. And one of these days, we're going to have to get around to talking about that as well. I absolutely enjoy this committee. I hope that we'll be able to do some good. I recognize extreme obstacles that I think crunching numbers is not going to be the solution to. I think the solution to it is probably gonna boil down to elbow grease. And I'm all out of that at this point. Thank y'all for letting me share.
Thank you, Dr. Odom. Appreciate that. Okay, so a little bit of wrap up and to kind of follow up on Dr. Hyman's comments, a little bit of homework that I think y'all can expect from me and the team at DCH via Sean and Kai and our facilitators. So to his point, we do have to put some, and I've had a couple of conversations about this with a couple of the commission members, but we need to put some order around our work and where we head next and how we get into some of the meat of this. So again, friendly reminder, our 3 charges within the statute are to look at opportunities around reimbursement and funding for providers, quality improvement for Georgia's low income and underinsured population, and service delivery and coordination. So within those 3 buckets, there are a whole ocean of possibilities of things that we can look at. And so we have to narrow down and figure out how to talk about the work in some sort of ordered fashion. And so within the next week or so, you should receive, I think, an email from someone from DCH on behalf of the commission, either with a worksheet or a set of questions and prompts for you to prioritize those areas from your lens. Number 1 on those 3 bullets, how to reimbursement and funding, quality improvement, service delivery coordination, and then identifying some key points or your perspectives under each one of those where we may need to dig a bit further, which will then help us kind of come back again. Certainly not going to be able to get through all of or even much of this by December. We've got 2 years to do this work. And so I think I would ask, there's a little bit of a matrix probably we need to consider of, you know, what's your highest priority, even though it may take the longest, what do we need to tackle first? What's the most feasible that we might be able to find some wins on? What may be the harder lift, and take a little bit longer. But so give some thought when you get those prompts so that we can bring those back and compile those and kind of take a look of how we organize this work. And then also, Dr. Hyman, to your point, based on the feedback of the commission at that point, I think that'll help inform who we might need to call in to provide testimony or education or to lead a conversation down any one of those particular things, or if it's additional information we need related to systems, or if we want to call in caseworkers and navigators or talk about the systems, or a state budget expert, or you know, someone that, plenty of folks that can talk about that. But does that sound okay to my commission members?
Yes, thank
Sounds
you.
good, Kaylee.
Yes.
Yep, sounds great. Thank you.
Okay. Any parting thoughts? Grant, thank you so much for your time today. I know that was a lot. There's a lot of really hefty data in there, and appreciate you being willing to share that with us and kind of further set the stage between what's happening right now and what our uninsured population really looks like, where those opportunities from a number standpoint exist, recognizing against the other comments that there is plenty of work to be done across the continuum within that world. So appreciate your willingness to answer our questions and be with us. We may come back to you at a future date. Any final thoughts from the commission members?
Just that I'd love to have the conversation as maybe part of that priorities and process about how to open this up and make sure that we get input from the public and the communities that are going to be most affected by the recommendations we come up with.
Sure. Happy to have that conversation. All right, then. Please hold tentatively October the 24th. That will be a little bit tentative on how quickly we can get a consultant off the statewide contract lockdown and geared up and ready to work alongside of us. We've got a deadline to meet in December 1, and that's going to be here before we know it. But thank you all very much for joining us today. Please don't hesitate to reach out to DCH directly or to me or amongst yourselves or whatever the case may be, but always available and appreciate your time and willingness to participate. So thank you all very much.
Thank you, Kaylee.
Thank you.
Thank you.
Thank you.
Thanks, Kaylee.